What is value-based care? How does it work and why should you care? Welcome, I am the medical bill whisperer, the previous billing manager turned patient advocate, helping patients like you with answers, insights, and solutions. Let's start with what it's not. It's not fee-for-service. Yes, there's a special video on that. Fee-for-service is the most current model in the healthcare industry that calculates a value and price for every single item, procedure, drug, service, lab, visit, report, test on a case-by-case basis. Care is based on the quantity of services, not necessarily the quality. The answer could be value-based care, a system aiming at streamlining medical care, improving health outcomes while lowering the costs. There would be three main goals. The first one, the best use of resources. Nowadays, more services have not led to a healthier population. On the contrary, the US population is sicker than most or even all developed countries, while overusing diagnostic and therapeutic resources. Streamlining that care through cooperation, communication between providers should eliminate duplicate services and wasted effort. Reporting on how services are used could lead to better protocols, more efficiency, and therefore lower costs. The second goal for a value-based care system would be improved health care. Payments right now are based on defensive medicine or conventional medicine, and I have a special video on that, which are routine practices for physicians trying to avoid medical errors and therefore lawsuits, or sticking to protocols established without much thought for costs or less aggressive alternatives. Data collection and analysis under the value care system could lead to standards of care that are more efficient, place less stress on patients who undergo duplicate or useless test procedures, but also lead to better quality of care and life. And it would also focus on prevention and lifestyle changes before chronic or serious conditions can develop. The third aspect is cost containment. Fewer services save money. More efficient medical protocols lead to faster, less aggressive, but better outcomes, and therefore money saved. Prevention efforts are cheaper than chronic condition treatments. In a word, all parties win. Who are those players? Well, of course, all doctors, providers, but also hospital facilities, the big insurance companies, and federal and state agencies such as Medicare, Medicaid, TRICARE, but also insurance plan administrators, supportive entities such as billing services, shareholders, investors, IT systems, billing systems, EHR, EMR systems. Of course, employers, especially those with self-funded plan, and legal mandates, of course, should be taken into account, all with keeping you, the patient, in mind. With promises of better medical care at a lower cost, with improved health outcomes, can only be good news. The even better news is that this strategy already being implemented a step at a time. So what could value-based care look like? Well, let's go through three examples. The first one, capitation. This system has already been in effect mostly with HMO plans. It's a way where a medical provider receives a set amount of money to cover anticipated costs to treat one patient over a certain amount of time, such as a month. For example, PCPs, primary care physicians, or some specialists receive that payment upfront for less complex therapeutic treatments to diagnose conditions to undergo preventive care as well as some injections, immunization, provide counseling, education on nutrition or lifestyle. So your provider is paid in advance, will handle most minor routine care, but may be affected negatively financially once you are referred to a specialist or if costly measures or prescriptions must be prescribed. So there are advantages. Yes, one PCP that manages your care will prevent duplication or excess services, leading to less errors, less waste, and therefore controlled costs for the insurance and you, the patient. But HMO patients over the years have always complained that sometimes the PCP contains too much of their care. Getting referrals for specialists or for certain procedures can be difficult to obtain, and many times a patient may have to fight through appeals or even go out of network in order to get proper care. Second example of value-based care is what is called pay for performance. You might as well call it bonus. It is a model that offers financial incentives, bonuses to medical providers when they meet certain performance benchmarks. For example, longer survival rates that are difficult to measure are broken down into criteria and benchmarks that are easily met. For example, lowering of blood pressure, weight loss, or smoking cessation. There are advantages to such a system. Prevention is highlighted and lifestyle changes. There is less waste, less duplication of services, and therefore costs again are contained. But there are also problems. Who sets those metrics for reporting and how? The care driven by outside perimeters may affect or will affect one provider's reporting. For example, if I cannot achieve weight loss in a patient because a different physician has ordered a prescription whose side effect is gain weight, and also the goals being too short-termed need to set a specific deadline could also affect overall care. But the most promising value-based care system by far is what is called ACO, Accountable Care Organization. This system is already in place for a number of Medicare and Medicaid members. Medicare is for patients usually over 65 years old or with certain chronic conditions. Medicaid is for low-income and individuals with disabilities, among others. The good thing is once Medicare imposes a specific course of action or a specific system, the rest of the healthcare industry follows. Overall idea of an ACO is for a group of hospitals and medical providers to come to associate in order to coordinate higher quality, lower cost care to the group of patients under their umbrella. If the ACO can deliver care, for example, keeping patients out of ERs or hospitals, reducing the number of days inpatient, can earn financial incentives, basically balancing sick care with preventing measures and improving individuals' overall health statuses and outcomes comes a financial benefit. Yes, there are advantages. High coordination and levels of communication among all treating physicians eliminate duplicate services. Costs are therefore lower, and patient experience usually improve. The ACO can review cases and data, get feedback, leading to more and more improvements. Quality of care be adjusted to different populations, genders, ages, and so on. Are there problems? Of course. Reporting measures, again, are usually for general population and may not apply or be skewed towards many individuals. Choices of providers are limited to within the ACO, almost like an HMO. And the task of maintaining extensive coordination between a number of providers can prove difficult. Keeping the balance between cost reduction but profits and health outcomes and better healthcare is going to be a very difficult and complex balancing act. And some medical associations have already raised concern. Increased paperwork to report so many measures and benchmarks, limited use of clinical parameters to assess quality. What about those sicker or non-compliant patients whose data can negatively affect a provider's rating and therefore income? What about the goals too short-term or set to meet deadlines, not always realistic? What criteria and who determines feedback and suggestions for improvement? Adaptation to yet another major change can take efforts and time on part of medical providers already stressed to the limit. If there are conflicting medical goals, and that can be expected, for example, that patient who cannot achieve weight loss because a different physician has him or her on a prescription that causes weight gain, then what happens? Also, directed care from administrators or non-doctors can be encouraged over comprehensive medical care by doctors. Standardized reporting measures can be too restrictive, too narrow, or too generalized. And costs will still guide medical care because income will be based on criteria established by insurance companies and external administrators, not necessarily good standards of medical care. Also, what about negative financial consequences for providers when their patients meet unintended, uncontrollable medical events, lowering the outcome scores of a population too sick to recover or improve? And that can affect a lot of specialties. The answer may be that, well, there is no choice but change. The existing fee-for-service system is no longer working. Patients who either delay care or drown in medical debt, to legislators, to insurers, to medical providers, it is too costly, too inefficient, and medically failing. While the value-based care model is only in testing status still, it is a much talked about alternative, but its implementation, when accepted and legislated, be the answer. Medical providers' reluctance to change the payment structure and their lack of enthusiasm at adapting to new landscape have been known to slow down implementation of new protocols and systems. But while their concerns are legitimate and confirm many patients' complaints, their acceptance and adaptation must be a major determining key. Is there hope on the horizon? Yes. Will it be an easy task? No. The will is great. There should be a way. I thank you for watching. Your likes, comments, and subscribes help the channel grow to reach out to more patients like you. Thank you.